Hi, good morning.
Kelly, glad you
Made
got on.
it.
Sorry for all. So glad we were able to get you on this time. So sorry for all the problems with getting the rate.
That's all right. We got it now. We're good.
Good. I have a slide carved out so you can kind of provide feedback since you haven't been able to join.
Yeah, I watched
last
last month's meeting, so I did do that.
It'll be after all the kind of after all like the sub committee presentations and things. Don't worry, I'll cue you for it. So.
You're cutting out a little bit.
Oh, am I? Thank you. I'll need to make sure I'm connected to the right. That fixes everything. We got a pretty good group here. Colleen and Sandy and Susan, Bill, Grace, Jim, Vicky's on, and Mag, Susanna. So we're getting there. We'll give a minute. I think Kate should be joining in just a second. So, and then we'll get started. So good morning, everybody.
Morning.
Morning.
Kate just messaged, she'll be on in just a minute, but we can go ahead and kind of move forward so we can stay on time. And Karen, welcome. Nicole, I know you're, I think, subbing in today on the DCF side. So today we have one more meeting. This is our penultimate meeting. Very exciting. It's been fun to get to meet with all of you on a monthly basis and sometimes a little bit more so far. So today we'll be kind of just briefly reviewing last meeting and our timeline. We're going to come back, just kind of highlight our goals, which I think are actually fairly stable at this point, and we'll do our subgroup meeting report outs and discussion, and then we'll have a visualization discussion and a little examples that Susan has put together, which is I'm very excited about. I'm sure we'll have some opportunities for feedback there. So I think with that, we'll kind of continue to move forward. Anything anyone want to announce before we take any further actions? And I see Kate's also joined. So good morning, Kate.
Good morning. How is everyone?
Good. And Bonnie and Ben, nice to see you guys as well. Okay. So we're going to do just a quick recap, and actually I was going to pass off to Kate. Kate, are you okay to just kind of highlight where we are and kind of our process and things?
Sure, absolutely. Good morning, everyone. I first want to say, reflecting Brad's perspective, also the commissioners, we continue to be so indebted to all of you for the incredible engagement, insight, the generative discussion that this group has been involved in, particularly for the intermediary work between meetings of the 3 work groups. Honestly, it is just tremendous for the department. Really, I think this learning process for us as we're visioning something different than what has been the norm for historical practice. I just can't say thank you effusively enough. We're really grateful. The last meeting focused on the initial report outs of those 3 work groups. I think we all determined, because of the nature of the work, that it would be useful to convene those bodies to really get to a more granular level of detail. So as you know, those 3 groups first centered on establishment of principles. And that group has done an incredible job, not only of the sort of specific task of the framework, decisional framework, and ethical framework, frankly, of the data points that we'll choose, but also really commending to the department an overall frame for our data transparency work beyond this project. So it has really served incredible 2 purposes. So that principles group, I think, sets context, gives us a litmus test in terms of our overall activities and selection of what will be featured on the dashboard. The quality group, I think, reported out on really seminal discussions, particularly building out the domains in which we want to see information featured, not only presently available data, but aspirational aspects that we're looking at building in plans to be able to surface and measure. And I think one of the pieces that started emerging last meeting was the intersection with other sister departments of state, not only human services but education, and looking at that as a major feature around the social determinants work. Finally, the 3rd group was very helpfully able to leap off the package of descriptors of kind of the financial sustainability of the program that had been developed and longstanding championed by Deputy Commissioner Gilbert, really starting to discern what amongst those features would be most compelling and useful in terms of the profile on the dashboard. So I think that initial report outs started to surface an orientation. I'm going to defer very shortly to Brad. Really, today is building out on that work, which I think has continued a piece since then. Final thing I'll say is the last meeting we started to think about the kind of nuts and bolts of the data visualization. And I just want to say again how excited we are to work with our colleague, Susan Smith. She is leading the efforts around translating the priorities of this group into a format that will adhere to the priorities that have been identified. So I think today is just really continuing to move forward on this. Brad's going to talk a little bit about the time frame. I do just want to wind up by saying that for those of you who may still be concerned about the kind of parameters of the executive order, I think we have broad agreement with the governor's office around continued work of this body and extending the time frame that was originally articulated for the report, which we're now pointing obviously to July on that. So while the EO has not been reissued, I think we are comfortably situated, and my expectation is at some point that it will be formally reissued on that basis. So Brad, back to you. Very happy to be part of the discussion this morning.
Thanks, Kate, and just appreciate that very thorough recap. I can't really add anything else to that, but I do just want to remind everyone we are streaming live on YouTube this morning. And if you're not speaking, just as a reminder, I think to mute yourself, which I think everyone is. So we'll keep moving on. So just in terms of a kind of a reminder, kind of we've grounded ourselves in this lens of health equity and population health as we're thinking about this transparency work. So just as a reminder, thinking about our typical, or just to frame this a little bit, so this circle is kind of a population here, and then within the population, we often think about physical or mental health, social or spiritual well-being, community health and well-being and then communities of solution. Communities of solution are really empowering communities to make decisions for themselves to allow them to make informed choices about their own community well-being. And so on the left here, we think about improving the health and well-being of people. On the right, improving the health and well-being of places. And at the bottom, we think about improving the systems of society, such as we know that things like systemic racism are greatly impacting various communities disproportionately in terms of how they impact people's health. So just grounding us in that. In terms of our timeline, we are approaching the end of our timeline here. We're approaching July, which will finalize our recommendations. We've continued to meet, as noted, for our finance quality and principles. And really, we've made a lot of decisions already about 1 through 6 here. And so we're really just at this point kind of finalizing the work that we've started and making sure that we've dotted our I's and crossed our T's as we approach the finish line. So we have one more meeting after this. And I think at that meeting, we can kind of preview and look at a kind of draft report, which I think is likely to actually take the form of a PowerPoint deck similar to what we're doing, that we will then either annotate or send along with a large description of what the work we've done. So in many ways, I think we can feel hopefully that we've gotten pretty far in our time frame in what we've done so far, and pretty happy, or at least I know I'm really proud of the work, and also so glad to have so many wonderful people to be doing this work with, because it's, for me, been a pleasure. And I suspect, I think I can speak for Kate and Susan and say it's been the same for them. So again, this is our penultimate meeting, one more end of June, and then report will be finalized and sent out right after that one. So proposed goals, these are kind of, I think we're pretty much in a finalized state here, but I think it's worth running through them just again to kind of remind ourselves of where we are and where we've come from and what we've kind of set on as the goals of this work. Identification of a core set of currently available equity-informed quality and cost data points that will be reported out publicly on a routine basis. Identification of means of measuring program impact on population health, social determinants of health, and other areas that need further time to implement. Benchmarking our performance on the core measure set, and also aspirational measures as that becomes feasible over time and against performance of other states. Visualization of data and accessible plain language electronic dashboard format that enables, one, a broad view of measures for the purpose of program accountability and continuous quality assessment improvement. Drill down capacity for purpose of routinizing access to raw de-identified data, schedule refreshes of the data, and push alerts to queue interested parties to updates. Take a brief pause. Anything, I know we're getting close to the end, anything that seems amiss here or that we're missing, I just want to provide a moment of commentary as we kind of wrap this up. Good opportunity for me to take a sip of tea. Okay, so we'll move. Oh, Karen, I see your hand, please.
All right, just a quick clarifying question. So there'll be an opportunity to review the final product at the next meeting, and then will there be a public comment period after that, or is it just the board that's finalizing those recommendations?
Kate, do you want to weigh in on that? I think it's just the board, but
Sure. Yeah, no, Karen, that's a great question. The EO contemplated the board would make the report to the commissioner. So I think we rely on all of you as kind of emissaries for various communities, kind of embodying that role of surfacing further nuance on this that might be helpful in the final report. So I do not anticipate we will have a formal public comment period.
In that case, it would be helpful to have maybe a week after the final meeting so that we can gather input from partners and I don't want to purport to speak for other people, if that's okay.
Yeah, I think that's entirely fair. And we defer to the board to let us know what time frame or latitude would be most beneficial in terms of, you having that time.
Agreed. And I would just add that pretty much, at least from my perspective, the language that we're seeing in this slide deck will be probably part of the report, and the report actually will reflect a lot of what we're working towards now and what we're seeing. And so if there's language that this is obviously all publicly reportable, and if you want to get feedback, even starting now on things like this from others, I think that's a very reasonable place to go so that there's even more time before the final meeting, because I feel like these, especially like these proposed goals, are probably pretty set. We haven't changed them in a couple of meetings. So, and I think, at least from my standpoint, I would not want to edit these any further. This seems to be the reflection of what the board has come down with. And I think from where, while we as DSS will be putting together this deck, it should be a manifestation of what we all have come to an agreement on.
Right, and I'll just wrap around to say the obvious, and that this is an incredibly important watershed moment in time for DSS. With receipt of the recommendations of the board, that's launching the initial phase of the dashboard effort. That we, and I know all of you, regard this as an absolutely dynamic process where this is going to go on an evolutionary curve of not only building out more facets, that as we grow to have more capacity around particularly the social determinant measures, which is an explicit goal for Commissioner Gifford, and I know the governor, over time, I think there's going to be a number of important opportunities to really evolve this. We will definitely plan to present those to Medical Assistance Program Oversight Council and the Behavioral Health Program Oversight Council. Also the long-term services and supports rebalancing body and our member groups for the purpose of really continuing to collect feedback. So again, this is the kind of best encapsulation of the recommendations of this really august board that has incredible measure expertise. But that will be a process that we'll use ongoing. And I hope, Karen, that's probably more of what you were trying to get at with your original question. We don't regard that as a static process.
Any other comments on this or questions pertaining to that? All right, seeing none, we'll kind of move forward. So just as a reminder, we've already discussed these. We've kind of framed this in terms of some of our initial decisions around audience, a focus on the general public, including but not specifically targeted to policymakers, consumers, and researchers, as a transparency vehicle and platform, electronic dashboard web platform with visualized data and repository for other reports and data sets, which Susan has started to mock up, and we'll see kind of the initial thoughts on this for feedback later. Data stratification and access, so key indicators, e.g. geography, race, ethnicity, disability, would drill down other capacity to permit researchers to download raw de-identified data in comparison across states, regions, nation, payers, providers, time. And then identifying measures in all categories that are equity sensitive and highlight those in specific public facing display. So again, just grounding us in some of the conversations we've already had and kind of what our base of decisions are at this point. Just pausing for a brief moment. I see Susanna, your hand's up, so please weigh in.
Hi, good morning. Yeah, I love this. I have no concerns about these decisions. I'm curious whether when and how you think the conversations about the feasibility of the data stratification and how that will happen. I know there's been a lot of thought in DSS about how to get good, accurate data. I know there's concerns about sort of how that data is collected and where. I'm thinking particularly now about REL data. So we haven't had a chance much as a board to talk about that data stratification piece, and I just wondered what your and Kate's thoughts were about, what's going to be feasible and how and when that'll become apparent.
That's a great question. Actually, I might ask Susan to jump in because I think she's really the expert within DSS on this and has been moving forward with this effort. So I'd love to turn it, Susan, over to you if that's okay, just to really weigh in.
Sure. I think as I've probably mentioned a couple times that we're really building this in as part of a concurrent process that we're doing to build out an enterprise-wide dashboard within the agency. And part of that is involving a surveying, I call it kind of a survey process of the various divisions, including Kate and Brad's, in order to decide to identify, kind of what are available and readily accessible, data. So I think part of that process will help to inform this. My thought is that for that next meeting, we really do need to get to those brass tacks of based upon those domains that we've decided upon. And thinking about, and I'm going to talk about this a little bit later when we talk about the transparency, the development plan, is kind of what's feasible at various phases. So really trying to coalesce on what we're going to put in for that kind of first phase of this dashboard, and using that next meeting to really get solid and make sure that we're all on the same page in terms of those data points. So again, using the existing process that we've started to stand up already to start to identify what we have and crosswalking that with what we've already decided here that we want, and then kind of tying that back to the various phases that I'm going to outline today to see if that will help us to kind of move forward and make sure that we're all in agreement in terms of what is practicable and what does support the priorities of this board.
Fantastic. Susan, it does not surprise me that you have a plan laid out. Thank you.
I'm getting old. I got that Civ mind going, so I got to write everything down.
And I think we acknowledge that we want to see improvements in that data gathering, and Susan's really leading that effort. But I think across the board, as part of this effort, we know we need to have better data so that we can actually stratify things accurately. That's useful information for both us as an agency, but also externally as we do that. And I think this will be an ongoing conversation, kind of as Kate already mentioned, like this is an ongoing process as part of this discussion, but also will not be done by the time this report's finished.
Yeah, and I'll just build on both Susan and Brad's remarks. And I really thank you, Susanna, for asking this, because this is a really central question for us. And we're so fortunate to have Susan with not only her expertise, but her energy and momentum around this. I do just want to confirm that this is going to be a major work in progress for us, not only with our kind of present mechanisms around REL, which are pretty parochial. I'm just going to say, and that's some of this is what is actually solicited and embedded in these federal programs. And there's a lot of work to do from an advocacy standpoint to expand that lens to descriptors that more meaningfully capture how folks view themselves. So, I mean, important to acknowledge there's also plenty of descriptors that we are not presently building in, like the SOGI data. Personally, this is extremely important to me that we're not just saying, well, that's the norm for Medicaid and that's an acceptable resting point. So I definitely want to call that out also. I think we have a little background noise that folks could go on mute. That would be great. But please do press us in terms of, I said that we had fascinating discussion about this in the principals group. We expect you all to help us remain accountable on these pieces so that we're not just kind of preserving what we viewed as the historical norm.
Thanks, Kate. Any other questions or follow-up on that? All right, so moving along, similar format, basically same format with possibly a little longer presentations today from last time. We're gonna have our subgroups report out. We'll start with quality measures, we'll then do principles, and then our finance subgroups. So about 5 to 10 minutes of a brief report out from each of those, and then we'll have discussion up to 25 minutes as needed. I'll probably cap it at 20 just because I wanna give Susan adequate time at the end to talk about visualization. And also, Kelly Phoenix unfortunately didn't do a good job on my end of making sure that she had gotten the appropriate invitation to the last meeting or two. And as one of our member advocate representatives, I want to make sure she has an opportunity to weigh in after the presentations. So just of note there. So we'll jump in. I'll pass it over to Susanna and Susan, who are going to kind of walk us through where we are with our quality subgroup work.
Susan, you want to start or do you want me to start?
Suzanne, I'll let you start. I'll jump in.
Okay. Morning, everybody. The quality subgroup has had terrific support from Brad and Susan moving these pieces forward. And most of what you're seeing in front of you is familiar in terms of framework from the last meeting. And what we've done is start to put some more actual measures or concepts or details into this table. I don't think we think this is done, but I think what we're hoping is to get some feedback from all of you about the pieces that we've added. So I'll start by just sort of reorienting folks in case you either don't remember or it's been a while or you weren't here last time, to sort of how we've set this up. And then I'm not going to read every word on the page, but I will walk through the boxes quickly with Brad's 5 minutes in my mind, just so that you can actually see what's here. So again, we started with categories of measures that we might want, and so that's what these rows represent. At the top, you see population health. One of the conversations we had in our last meeting, again, was sort of that this is meant to capture both primary prevention. How do we keep people healthy in more traditional clinical ways, but also a much broader sense of the important aspects of, things like, as you see here, school readiness, like really a broader perspective on what it means to have a healthy population that can be well and high functioning. The next row is around clinical quality, and we think both about primary care, acute care, and chronic disease. This captures more traditional quality measures, as you'll see as we go through the boxes. The third row is social determinants of health, and one of the conversations we had was there's obviously overlap with this, actually with almost any of the other rows, and particularly the population health piece. So we focused this category largely on increasing efforts to directly address social determinants through capturing crucial information, making assessments, getting referrals, making sure the loop is closed on those referrals, and then ultimately seeing whether within the Medicaid program in the state, we can see some improvements in some key social determinants. So there's some potential overlap with that with the first row, but we felt like it was useful to have that because it is such a focus, its own identified row. The fourth row is around enrollment, access, churn. This is also related, as you'll see in the measures, to things like adequacy of the network, making sure that we understand how fast people are moving through the system and whether they have access to both providers. And then, not really a set of measures, but a placeholder to make sure that we're paying attention to all of the above or thinking about individual measures that really address key populations for the Medicaid, the key populations for Medicaid, and then managing costs, which of course is the other side of our work as a team. So those are the rows. What you see in the line before you get to the boxes is just a reminder that our hope, and Susan's going to talk about this, is that we'll have the ability to look at any of these things by demographics and geography, and then across the top you see comparison with states. The columns are using a traditional framework of outcome process and member experience and satisfaction. Not every box is filled in, not every box needs to be filled in, but we try to think as we identify potential measures about opportunities for looking at outcomes versus process and identifying member experience and satisfaction. So that's your reorientation. And what's new here is there's many more measures here. So I'm just I'm trying to think about how to use your time wisely. You all can read, but I feel like it's useful to name some of these. So I'm going to give some examples from these boxes, if that's all right with folks, without going through every single word, but I think that it just gives you a feel. So in the population health, you see things like school readiness, but you also see prevalence of chronic diseases like diabetes. This is in the primary prevention. And then, you see something about homelessness, which you'll see again in the SDOH. This sort of highlights where we felt like things could fit in a couple of places. So here we have it thinking about it at the population level. For process measures, what are the processes that we know are associated with achieving those better population health outcomes, things like wellness visits and screening and timely referrals. And then thinking about member experience and satisfaction. In particular here, thinking about whether or not the kind of care that's being provided is culturally and linguistically competent. CAPS can apply across a number of these rows, and Data Haven has some potential data that would be relevant for this piece. The clinical quality row, we're focusing more, again, not listing individual measures so much as reminding you of measure sets that already capture a lot of clinical quality, particularly Medicaid and CHIP core measures. There's both outcome and process measures there, and OHS core measures. I think this is particularly in reference to the work that's happening right now in the Quality Council to define a core set of measures that payers would use and wanting to harmonize with that. And then we highlighted oral health as a particularly important area of clinical quality. When we think about experience here in the clinical quality setting, we're thinking specifically about things like, do you have translation services? We discussed an important tool that was created by a team at Yale around the experience of bias when you're in a hospital. And we've talked about using a person-centered primary care measure, which allows you to directly hear from patients in a short survey about the continuity and comprehensiveness of their primary care. Again, I sort of mentioned this when I described social determinants of health, so I'll be brief here, but we're thinking about really specifically here, can we capture data on whether an assessment is done and a referral? That's sort of the process, right? Are we individual patients taking the time to assess this and give them referrals where needed? And then an outcome would be whether some such things were successfully addressed. And then we might track key social determinants like homelessness and see whether for our population as a whole, we are successfully through the provision of these resources achieving better outcomes. And we talked a bunch, and actually I'm going to pause on this one because I wonder if somebody else wants to pop up around sort of how do you think about member experience and satisfaction directly related to being asked about social determinants and the ways in which that kind of work can be done well or less well. Does anybody on the team want to say anything about this particular box? Because we have this arrow here about collaboration rather than judge practice, and so I don't know if anybody wanted to speak to that. Okay, I'm going to keep moving, but create an opening for that. And I think we can do this pretty quickly because I'm trying to watch the clock here. Enrollment access in turn, I think, is largely things that we've seen before but are really important. How many members? Do they have a primary care provider? Do we have enough specialists? And we've talked a little bit about additional access measures that might be possible in the future. And I think we're thinking it may be useful to directly survey members on access. The special populations, last time I didn't know these initials, now I do. But these are all, populations of folks who are particularly important in the Medicaid population. Money follows the person, folks who are incarcerated, perinatal, pediatric with special health needs, et cetera, et cetera. So just making sure we're keeping an eye on these populations. And then I think there's a cost group that's actually going to talk about cost, but what we put here is just a note that we can think about efficiency measures and both over and underutilization in this area. I'm going to stop because I'd much rather hear from all of you and make sure that Susan or other folks from our group, if you have things you want to add, and then I think we're talking about what the next steps are, right, Brad?
Yeah, I think you really, well captured this, and I too would be interested to hear folks, feedback, because obviously this is really going to drive that next piece about how do we visualize and operationalize these domains.
So maybe we'll just go, do you want to do the quick punch list, Susan, or do you want to highlight this? And just, if we can keep it to about 2 minutes or less, and then we'll get everyone's feedback. We can go back to the prior slide for the discussion period.
Certainly, I can probably do it, like name that tune. I can do it in like 30 seconds or less. So this is just a reconfiguration of the punch list that we shared at the last meeting, and just really distilling it to some of those core high-level areas that we need to focus on as we start to move forward to actually starting to build this up. As we discussed, we really obviously need to kind of finalize those measures, figure out those disaggregations and how we're going to unpack some of those domains. Clearly, our commitment to the disproportionality, disparity, the REL pieces, and other examples of inclusion and equity, just making sure that we are thinking about how do we best represent that. And those metadata pieces, I know that the financial subcommittee group folks have noted in particular the importance of having a dictionary, and I echo that sentiment. And I think that that's really going to be critical for the actual kind of dashboard visualization, the dashboard operationalization, is to have those metadata pieces, that dictionary, as well as really being clear about kind of the various data sources, particularly since we're looking at potentially getting data from sister and partner agencies. So that's going to be really important that we have that type of lineage and archival information. And thinking about, and some of this is what I heard this morning, is those mechanisms ongoingly for our identification of those kind of innovative measures, expanding the menu of the dashboard, and enhancement of the experience, and the actual interface pieces. So it's getting solid on those couple of things, so that as we start to move this forward, that we have the necessary infrastructure pieces, and that we also make sure that we have a mechanism to get ongoing feedback and partnership to make sure that it continues to be maximally meaningful to the various stakeholders.
Perfect. Thank you, Susan.
Sure.
So I want to open it up for discussion. People's thoughts on this, we can go back to the prior slide just so that people can have it in there, can see this matrix if that's helpful. Comments, questions, input, concerns, any of the above, please, if you don't mind raising your hand. I see Karen, your hand's up, so please go ahead and start weighing in, and then we'll go to Sandy after that.
Sure, just really quickly. I mean, I think I think I will have more comments in at the next meeting, but a couple of things that I see that I don't think we talked about are, in addition to churn in and out of Medicaid, churn between Medicaid and CHIP and Medicaid and the exchange. Those are really good indicators of how well administrative processes are working. And I see oral health listed sort of writ large, but I think it would be helpful to have some more specific oral and mental health measures or behavioral health measures, and also process measures of integration of oral and behavioral health with physical health. And to identify exactly what those are, it would be helpful to have seen some disparities data, right? You want to be looking at specific things that would improve existing disparities. And I don't necessarily know where those are in the Medicaid data, but there are plenty of examples of ways that other states have honed in on integration process to try to improve experience for certain conditions.
Thank you, Karen. Sandy, and then Grace.
So, I agree with, I was going to say with what a little bit of what Karen just said, is that behavioral health really isn't specifically noted in any of these lists. And I don't know if that's a decision that was made for a particular reason, but it seems that that's, you can't separate it out from so many of these other things, social determinants, it just basically everything else. And the other concern I had is, again, just taking it from a very personal view of dealing with families, is that where you see referrals, like timely referrals and successfully addressed, referral at the individual level, is that a referral made really isn't a good measure of anything. It's really the referral, because a referral made, unfortunately, I've seen is like, well, you can check off a box in an EMR that you made the referral and you get whatever credit for it. But what you've done is given a mom a list of names of people for her to call. And in my view, that's not really a referral. That's a list of, it's a piece of paper that anybody could get. So I think we need some endpoint there too, is like a referral made and completed or not completed for a reason or whatever. But I think that that's really, that's a huge barrier for so many of the patients that I work with.
Thanks, Sandy. Grace?
Yeah, so I'll agree with everything that's been said and excuse me, add on. I particularly like the way we have homelessness under social determinants, where there's a process measure and an outcome measure. And, you know, it's also referred to above in the, I believe it is in the population health area. So to the degree to which we can try to be consistent with that with other social determinants. So we've got, for example, access to food as a process measure. And to the extent possible, I know some of these are aspirational, but to what extent can we have an outcome measure related to food security? You know, what is the outcome we're looking for, and individually as well as for the Medicaid population? So that, you know, for ones that we consider key and important social determinants, we're being consistent in how we cross the line of population, individual, and outcome and process.
Thanks, Grace. Bonnie and then Dawn.
I just very briefly wanted to also echo the point about calling out behavioral health and also having the integrated framework. And I do think what Susan laid out about the data visualization, even if some parts of it are aspirational, will give that opportunity to be able to look in an integrated way across domains.
Thanks, Bonnie. Dawn, go ahead, and then Kate.
Thanks. Two quick comments. One is that in terms of access to food and the comments that were just made, under CHESS, we are doing testing of certain questions that may be used to test food security, specifically in the homeless population, hoping that we're going to be able to integrate those depending upon what we learn over the next couple of months. University of Connecticut is doing that. The questions, and we can share what those questions are. It's based on literature review, but we are going to test that one out. It's a little bit tricky when you start to talk to providers about how much responsibility there can be for food security and how we actually get at that as an outcome measure. Important to measure, but we need to make sure that we have the training and the interventions in place so that we're not measuring something that otherwise isn't something that we can systemically point to and hold providers accountable for outcome. So it's in a study this year. The other, and maybe this has to do with innovative measures, it speaks to a little bit about what Bonnie was talking about just recently. The integration of services in the whole person perspective, I think, is where we want to go, not just the measure of a specific individual healthcare delivery system, but rather the integration of all those systems around the individual, because we do have many systems, especially when you look at the special populations. Those individuals touch many, many, many healthcare systems, all of which need to be coordinated in order to deliver the person a kind of seamless response. To get at that, we're starting to test the impact of teaming of the various systems around the person. So we know that there are going to be caps that are going to be specific to every single cohort, and we have those. But those individual caps don't measure team experience. They measure the person's experience, a lot of times just with the provider, of a specific healthcare delivery system. Important information, no question about that. But getting at the teaming is where we're starting at, and happy to be able to share that. That might be a measure that you all could look to answer the question of, are the various systems coordinating around the person in a way so that the person's experience is literally one of integration. And we've done some lit reviews and done some, have a core set of questions that we want to start to ask around that, once again, to get at that whole person experience with the various systems that they interact with.
Kate and then Jim.
Yeah, that was so beautifully said, Don. And I just build briefly on Don's remarks to thank the group for raising these matters around the interrelationship of various benefits towards outcomes, as I think Grace has said consistently throughout this process. I just will say a bit more about Dawn's role here. She, as you know, leads this major demonstration grant from the federal government around rebalancing long-term services and supports. It has been a fulcrum point, not only for choice and self-direction in the community around traditional long-term services and supports, but for these questions specifically around behavioral health as a leading edge for integration and social determinants. And the CHESS work that she and many others have done, we hope is a model for so many of these aspects, as she said, not only the data matching, which we aim to reunionize the matching of Medicaid claims data with homeless management information services data, the cross-sector budgeting process, but then examination as we build model design interventions. And I know there's been a lot of interest in this board around how the data is applied in that way, looking at mirroring up the indicators around the social determinant. And in the case of CHESS, it's the housing stability, how that's the driver of the health outcomes. It's a contributor and determinant, and looking at rewarding providers around the expediency of that piece, examining other features, like Don said, the food security piece, which we have some in nexus with SNAP, but also some opportunities with other work, like the nutrition assessment work that the area agencies do under the Older Americans Act funding. So grading there in terms of, complementary efforts. But I think really the sky's the limit here. And on that, I'd say that there's some major contributing features to moving us rapidly. Don's group and her work under the demonstration grant. OPM's leading an effort that is going to be helping to make it a commonplace practice for cross-sector data matching. And I think the ARPA funds, really the American Rescue Plan funds, are the first examples of really that intentional piece around integration. I'll just wind up to say that a little bit obscured by the overall descriptor of use of Medicaid and CHIP core measures is the fact that there are many specific EH and oral health measures embedded in that subset. So I think we can circulate again, a link to the measure scorecard, but please know that it is very intentional to focus in those areas. And that's kind of a shorthand that builds in reference to a lot of measure types. So thank you very much.
Thanks, Kate. Jim?
Thanks, Brett. And it may be sort of implied or at least assumed in this, but I think that I just want to call out, there's sort of another domain that we need to think about as these measures move forward in terms of targets and actual deliverables in terms of both long-term and annual. For us, you're setting which of these are going to be several years of work to get to some objective versus what we in Heart Healthcare call annual improvement activities, which are those things that you're doing a year to build towards your ultimate destination, and trying to put a time domain in here in terms of which of those things are things that we want to set several years in the future to say it's going to take us a while to get there is going to be another cut of this that we need to be thoughtful about. Some lend themselves to that, some because you're not ready to really meet targets, and there'll be process measures that are building towards a capability to getting to a clear, demonstrable outcome.
Thanks, Jim. I think that's a really important point you're making. Kate, I see your hand's up, but that might be a legacy hand. Just want to make sure you didn't have me.
Oh, I apologize. Legacy hand. I will try to bring it down.
No problem. Suzanne, I see your hand up.
I wanted to say one thing I expected to hear from folks and didn't, so I just want to name, because it's in the back of my mind, is, this tension between an enormous desire to hear directly from members and not overwhelming people with surveys and patient-reported pieces. And so, again, this is a place where I suspect that Susan is 3 steps ahead of me in thinking a little bit about this. But, we have a lot of things in that last column, and some of the most important information could come out of that last column, and we also don't want people to feel like every time they turn around, they're filling out another survey. So I just think that's something we're going to want to put some thought into to be strategic. And again, Susan, you're probably already ahead of me, but I just wanted to name that because I didn't hear it from the group.
I don't know if I'm ahead of you, but I do echo that, and I think it's important that we are thinking about how do we continually capture member experience and sentiment, but obviously not have them have that survey fatigue and feel like there's over demand for feedback. So I think we do need to look at the balance and assess what we have and figure out how we can order these, prioritize some of this so that we are getting that feedback. But as I said before, that folks don't feel, every time they turn around, someone's handing them a surveyor. So I agree.
Thanks, Susan. Grace, and then Kate.
Yeah, I agree as well. And we've said this in some past meeting, but just to reiterate for the thread of this, the survey process is also one that doesn't guarantee that we get the full perspective of somebody. So how do we get the depth of their experience in a thorough way, especially with diverse populations we're talking about, limited language, technology capacity, et cetera. And sometimes it really does need to be focus group or open-ended conversation to capture that. So how do we balance really the expense or the intensity of effort that would take but the necessity of it to make sure that fullness is being captured of people's perspective and then not overburdening people at the same time.
Thanks, Grace. Kate.
Grace, I love how you put that, and we just are in absolute agreement. I know we've shared a bit about this in the past, but briefly, two pieces that we've been very excited about. So we as a program, have done a lot of CAP surveying, that traditional health plan type experience of care. We've also done mystery shopper and the like, but we really want to transcend that. So two examples, we have Dawn's group has done essentially use of life satisfaction scale data, so it can be empirically measured and tracked and trended over time, but really to the aim of is this intervention improving your life? What's your worldview of that? Are you actually happier? Are you more satisfied? Do you feel more engaged with community? And I feel like traditionally Medicaid programs have not had any interest in this, nor viewed it as reliable or probative information. So that's a piece I think we're really excited about. I also, Grace, totally resonate with what you're saying around, the vehicle of the survey. And I want to point to emerging commitment on part of the department of really taking that seriously, and particularly the work that's being done by Fatmata Williams, working with CHN on lived experience for the purposes of the development of our maternity bundle. And I certainly want to ask if Fatmata would like to weigh in on this, but it is something we're keenly interested in, generating ideas around how we build that in on a routine basis and start relying it as co-equally important in terms of how that informs how we continue to evolve. So definitely, Brad, I don't know if we can invite Fatmata just to weigh in briefly.
Fatmata is, I think, still, yep. Actually, do I see Fatmata still on? I saw. Oh yeah, Fatmata, I don't know if you're available or not. I wanted to weigh in at all. We can always come back if you are when you become available. But definitely concur, Kate, that really important to figure out how we're doing this, and definitely appreciate what we're hearing from members, especially around the maternity care piece. And I think thinking about how do we do this moving forward in a meaningful way, and also kind of balancing the overburden of asking for too much from members. I think that'll be an important piece, and probably something that's going to take us a little while to figure out and will be important to continue to get feedback on over time. So we have just a few minutes left for discussion on this topic before we move on to the next subgroup. So I want to make sure if any other folks want to weigh in on where this stands. One of my thoughts is maybe before our next meeting, we can try to break these out and even have individual slides for each of these subgroup, each of these rows or something like that to help flesh out some of this a little bit more, which might be useful as we get to our final product for this. Any other comments, thoughts? I think Dawn and Kate.
Just a quick thought. I was listening to Kate and to others talk about what amounts to this could require an investment. There might be an initial investment, an ongoing investment in order to actually provide the data that we need that measures the members' experience, consistent with some of the comments already made, like maybe these members wouldn't be the ones who would be filling out a survey. And so when I think in terms of what that investment might be, that might create access to us actually hearing all the members' stories. There might be a way to offset that investment through other variables that capture the answer to the question of, are we getting services to the right people at the right time, which could complement the quality members experience, right? And also reduce unnecessary expenditures. So if we do it right, and we make that investment to measure the experience of the person, and at the same time, we pay attention to the data analytics that are giving us evidence that the right services are getting to the right people through that analytical process, the savings associated with that multiple strategy might be sufficient to finance the ongoing involvement of that third-party third-party evaluation ongoing.
And then Kate, or Kate, is your hand down?
I'm sorry, another legacy. I apologize.
Sandy, I think probably final comment before we move on to our next subgroups, and go ahead.
Okay, and I just wanted to sort of point out again, the pediatric part of this, like an outcome measure of kindergarten readiness, the process measure of wellness visits, I think is not really adequate. Kindergarten readiness, you're already talking about a child who's 4 or 5, and so much happens before that. And having wellness visits doesn't necessarily mean that the child is going to get everything that they need so that they're ready for kindergarten or even the 3rd grade reading. There's so many other factors involved. So I think we need to keep that in mind.
Thanks, Andy. And I'll just I think we're going to have a lot of tension with this, is what we actually have available to measure currently and what we can or realistically can. I think that will be part of the tension moving forward, is recognizing that some of these measures may be inadequate or proxies for other things, and some things we're going to need to develop. And so I think we're going to have to figure out, we likely won't be able to do all of the above. So some prioritization will need to occur at some point along the lines, just given limited resources. And are we thinking about the importance of member experience and satisfaction over developing outcome measures, and what other agencies might we need to partner with? So definitely this won't be the end of this conversation, and really just the beginning as we move forward, because I can't imagine we'll have this all figured out, unfortunately, by the time we prop up our first dashboard. But I think it's a really important piece, that just recognizing that we might need to continue to develop things, and we probably will, and continue to think about, like, what other information do we need to gather so that this is useful information that can help inform us as a state and policymakers and other folks about how we're doing and where we can do better. So thanks, everybody. Really appreciate it. So our next group is the principal subgroup. And I think Grace and Karen were going to present and just kind of highlighted some of the changes from the last, from the prior meeting slides. So I'll pass it off to you guys.
Okay, so I will start and point out just one of the changes, and then Karen, I think, is going to focus on one of the other ones. But overall, these slides are very similar to what we came up with last time, except that we wanted to make sure that equity as a value and what it's related to in terms of social determinants, et cetera, was emphasized adequately on this first slide, but then reflected thoroughly and adequately on the second slide. Originally it seemed like it was implied, but we took a good look at it and thought that maybe it would be helpful to take what's really emphasized here, and if we could go to the second slide, just insert into the second slide where it fits to make it consistent across the two, so that the principles really reflect equity. So, I could read through them, but you'll just see in the first one, we added equity informed, 2 bullets down, dignity and health equity, and trying to see if that other, the last one has health disparities added in. And the one prior to that has reference to health disparities and inequities. So we really looked at the principles and figured out how we could consistently emphasize this as a major value and priority for the principles. And I'll just turn it over to Karen to go through the other change we made, and then open it up for the group.
Sure, yeah. So like Grace said, most of these changes are just to be more explicit about equity throughout. And then the second to last bullet, we just expanded a little bit to be clear that we should be careful of and cognizant of bias built into data tools, analytics, algorithms, just to try to keep bringing that to front of mind and leading with equity, so that we're not unintentionally exacerbating existing inequities.
Great. And maybe, actually, just make sure I'm going to the first slide to see if there's any further comments, make sure people have time to review. Any feedback on these principles? I think, again, important that we include this in our report out as part of that our final piece of our final product. So any feedback, and if not now, feel free to review this and can always provide comments further. But I think my guess is this subgroup is pretty close to kind of having a finalized product here based off of kind of reviewing this, but welcome feedback and thoughts. Go ahead, Susanna.
Two pretty minor things. I mean, I think this group's done a fantastic job, and I know Kate had stepped away, but I love Kate's request to being held accountable because these are really important and challenging. And so I think laying them out as principles is key, and thinking about how to operationalize these principles will be tricky. I'm thinking sort of how do you then lay this over the measures themselves and make sure that we sort of feel like we've been true to these. So that's my main comment is appreciation for this work and a sense that we're going to have to think about how to that for me? The one other thing is I'm noticing in this call out in the middle of the slide, and I just wonder if you guys can talk about how you thought about this, that the goal is attaining optimal health, and I read it as and attaining optimal socioeconomic status, regardless of race, ethnicity, disability, gender identity, or sexual orientation, but not sort of, sometimes people frame this as obtaining optimal health regardless of socioeconomic status as well. So sort of the choice of where you were thinking about kind of socioeconomic status as an equity issue versus something that this board is really trying to achieve for folks. It's not an urgent question if other folks have urgent comments, but I was curious about the thinking behind that.
Karen, Grace, do you guys want to weigh in first?
I'll start. I think the idea that just to emphasize, even though it's inherent to how we understand health, that socioeconomics drive health, but the social determinant piece of it is so related to the factors involved with socioeconomics that to point that out as part of what needs to be optimal is that with that in place, people are going to be healthier. So just to make sure it's pointed out, not just as a regardless, but as part of what we're striving to achieve. Therefore, the focus on housing and food and et cetera.
Do you want to add anything to that?
Sorry, did you say Karen? Oh,
yeah.
I'm sorry, I couldn't quite hear you. I think Grace captured it. I think it had started out with socioeconomic status being in the regardless of category, but because Medicaid is a driver of better socioeconomic status as well, it seemed to make sense to, and because socioeconomic status is a driver of health, that was why it was decided to move it earlier.
Susanna, do you have any other thoughts kind of hearing that?
No, I mean, I think there's always going to be tension in terms of how much we can ask the health system to do to address these things, but we're at a moment where I think the emphasis is on there's a lot we can do, and we want to emphasize that, and I'm supportive of that. I think in a context where my expectation is that there's intent to be very collaborative across departments in the government, and that this doesn't take away the importance of work that happens in other areas.
Appreciate that thought. Yeah, definitely recognize the tension and how to frame this. I think trying to be as kind of inclusive here in terms of how we're thinking about it, but definitely can understand that. So if there's other thoughts about that, welcome that, whether it's on this or any other points of the principal slides. Okay, seeing none, I think we can move forward. Like I said, it seems like I'll leave it here for just another moment to see if any folks have any other thoughts on the second slide, but any language concerns or any things that people want to comment on should feel free to. Otherwise, I think based on kind of limited commentary, we're probably at a pretty good place with these principal slides. Again, kind of thinking about pairing them with the goals and having goals and then principles of data use or principles of the kind of what were the processes of this transparency board or the transparency work moving forward. So seeing none, I think, again, we'll move forward, and I kind of figured this would happen because last time we didn't have as much commentary around this, which I think means that the small group did a great job of thinking through these pieces already and compiling a really nice product that we'll be able to put together into the final presentation or the final report. So we'll move on to our finance subgroup. So Bonnie and Mike, I believe I think Bonnie, you're gonna, starting out, but I know Mike's on to help as well. So I'll turn it over to you, and if you just let me know when you need me to advance slides and etc.
Okay, great. Thank you so much, Brad and everyone. I would say in many ways, our slides are very similar to our last presentation, and similar to Susanna, I'll walk through it sort of more briefly and allow more time for the discussion. One great advance since our last meeting was we had, I think, even more cross-fertilization of folks joining each other's subgroups. And as an example, we had Chima join us and dive a little deeper, which was great. So for phase one, we have our high level benchmarks. As we discussed at the last meeting too, we really are very fortunate in the financial metrics area to have well vetted metrics that have been reported regularly that we refer to as our standard metrics. They've been reported regularly, including to MAPOC, and they're also then posted as part of presentations on that website as well. So that would really be something that we can share very readily and can be part of phase one. For phase two, we actually have a lot in this area as well, where there are, again, sort of longstanding investments that have been made, often tied to major projects that we can also share financial metrics that are also tied to outcomes. So what you saw earlier in the presentations was on the overall quality metric grid, there are cost-related metrics that we want to make sure the financial metrics, when possible, are sort of interwoven and connected to the quality metrics overall. And phase three is some similar to what Jim said, more aspirational. We really want to be able to have an interactive financial data mart that also integrates the health equity lens, and to be able to allow anyone to drill down into various levels of care, various services across the system, and also looking at enrollment. One of the things we spent a good deal of time talking about is it's really important in many ways to think of enrollment as a service in and of itself. Similar to Karen's point about improvement in socioeconomic status as part of healthcare, helping members become members, helping members keep continued access to their enrollment is really critical to giving them access to a whole suite of services. I see Grace on my screen above. They'll have access to dental, they'll have access to transportation, they'll have access to behavioral medical, and we really want to be able to look closely at our enrollment in that regard too, as part of the financial metrics. And also there are a lot of challenges in this area, but looking at PM by service category and Husky component as well. So we can advance the slide, great. I think I probably covered this already. Let me, that I think in addition to our high level benchmarks, you'll see on a subsequent slide too, that we really want to, again, highlight the longitudinal data that we have in this area. We want to be able to show trends of Connecticut's share of Medicaid expenses and also the administrative expense ratio. And we, as we spoke a little bit about last time too, are very fortunate to have a very unique and strong system of care in Connecticut with a wealth of data that we can share publicly. Again, much of this data has been available previously. It's just somewhat difficult to access even for folks who work with it regularly. So the goal is really to have one place that anybody can go to and know that they'll have one source of truth, a vetted suite of metrics, and also the ability to have, we talked about both a data dictionary, but also possibly links to much more detailed reports for people who might be interested in that. Again, pieces that are already available, but helping have one place where the high level benchmarks are available, but there's an easy way to drill down. So we can go to the next slide. Here is an example of some of this trending across time that we have, or various breakdowns that are, again, everything on the screen now is already available, has already been presented previously. And we want to be able to have this be a key part of phase one. And also, as we allow drilling down, you see there are some notes on the screen. One example, the stability in the state's share of the costs overall as an example, and also Medicaid as a share of total budget. We want it to be that as folks do explore the data, that when they possibly are drilling down, are saving various snapshots, that they still will have some of the key takeaways available to sort of help guide people through the process. So next slide. And we also have for phase one annual high level benchmarks. Again, here you can see PM percent change, and again, Medicaid administrative expense ratio being very, very steady across time. And possible quarterly high level benchmarks as well that, again, are already readily available. So in many ways, the most of the general public, when we have years of data available, would likely be most interested in the annual metrics, but I think it's important to show what we do have already available and vetted. Okay, so for significant considerations, I mentioned the data dictionary just before. I think that it's really critical to keep in mind, again, the goals that Kate outlined at the beginning of that this is intended for a general audience, and we really do need to make sure that the language is as clear and concise as possible for any reader. That also truly helps, again, even folks who use the data very often. And I think mindful of what Karen mentioned before too, about when we're looking at health equity, and we want to be really clear that, and for all the transparency principles, that we're not unintentionally including information that might not be well understood and might reinforce let's say stigma or misconceptions. The data dictionary and the explanations that we can give are an opportunity to help people really understand what information we do have, what takeaways are very clear from that information, and also allow them to explore and bring other insights to that. We also really highlighted the need to focus on the story behind the data and to have narratives. It was mentioned before on the quality side, really making sure that we have qualitative data, that we have focus groups or self-reports in this space as well. And part of that is always remembering again that the data that we do have is primarily when we were looking at our service and utilization data, it's when folks are touching the system, when people are at their most vulnerable, and we really want to sort of honor the story that comes out of that from looking at the data in aggregate, but we don't want to lose the personal piece, and we want to have sort of a recovery orientation in all the stories we're helping tell.
Thanks, Bonnie. Mike, just want to offer, Bonnie, thank you for that really comprehensive overview. That was fantastic. And Mike, thanks for making me put the slides together. Did you want to add anything else, Mike, to this? Any comments or additional thoughts?
Just to thank Bonnie. I think that was certainly very comprehensive, and don't have too much to add to that other than it is exciting to be able to sort of think about the next stage in the evolution of how we try to use or try to capture some of the financial metrics in terms of the relationships to investment and or strategic aims of the program. I think that's a really exciting area to be able to think through with the group, and looking forward to getting to that next step. It's always been an interest area, and we've made some early attempts at doing that, but there's certainly a great amount of work to do there, and supported by the work that others are doing within the group on the quality outcomes. So just looking forward to that and some of the next phases, and trying to get more information out there that will be helpful to people who are looking to the program for that sort of information, and to help move the program forward in general. So just a word of thanks, and looking forward to our future work together here.
Thanks, Mike. So I want to open it up to the group for feedback discussion. Happy to go back to any slide that was already covered if that would be helpful. But open it up for input. Jim, please.
I guess it's just an observation, a little bit of how we want to display this. The financial part is going to be inexorably linked to utilization patterns and quality, and there's a blending there that we just need to acknowledge. And I think people are trying to get at it, and we've talked about it as to why some of those things are sitting in a quality bucket, yet they also have significant financial implications. There's no question that the PMPM is a great global measure, but the worry that everybody has is no care doesn't cost very much. And how we get at ensuring that specialty access to offset more downstream chronic conditions that are going to be much more costly, but in the short term could actually increase some expenses. That kind of dynamic we need to bring forward. So how we include into just the pure expense, but also bring forward important utilization metrics that tell us, are we actually providing the care that we hope to do for the dollars we're spending, is going to be an important mix that we need to bring together, and really not let them get too far separated, because it can be attractive to say we're really controlling trend in PMPM. We need to marry that up with what do our access and other things really look like? Is it supporting that we're actually doing what we want to do and controlling cost? You can do both. High quality, broad access can help you control spend, but you can also get there in a very distorted way. Is the only so my comments.
Thanks. Great point. Jim, Bonnie, I don't know if you guys, or sorry, Mike and Bonnie, I don't know if you guys want to respond.
I think it was a really great point, Jim. And I think that some part of that would be addressed by allowing the interactivity and building an interactive dashboard that captures the interplay between the various factors, especially for PMPM. Some examples are the behavioral health home dashboard and the population health dashboard that Beacon Health Options has, where it includes various expenditures, but it's in the context of a lot of other population metrics. So I think it helps give the context. So I do think a lot of it is how the framework is set up, but a really important point. It's a piece of the puzzle.
Thanks, Bonnie. Suzanne, I see your hand up.
Yeah, and this is really very much along the same lines. I'm really glad Jim said what he did, because I think this is why I like being on the quality side of things. I know which direction is better and which direction is worse, and it's harder with cost, but not necessarily always better to spend less. It's exactly to Jim's point. And so I think two concrete suggestions. I mean, one is, given that concern, Bonnie, I think you had some terrific suggestions, and there's this language here about telling the story. You know, we may want to think very carefully about, you know, which metrics is there directionality that's clearly better for members and which not, right? So I assume if we're thinking about how much we're spending administratively, you know, generally we don't want that to go on something, I don't know, again, this is not my field, and sort of seeing the administrative cost versus the service cost change in ratio there might be some sort of good versus bad there, whereas, you know, the PMPM going up but member health getting way better, that might be good, right? So I think the telling the story, we may want to try to give some information around where this is cost data, but there's not necessarily a good or a bad versus, again, I'm really oversimplifying. I'm a quality person, but I'm just saying, I think we may want to build some of that sort of, you know, maybe Jim can say it instead of me, but some language in that helps folks understand, you know, when there is a relationship to the direction we're going that clearly benefits members. And I wondered, my second suggestion was, it occurred to me that I don't know if this is in our principles, but this is one thing the principles group could think about a little bit. Like, do we want to make sure, and maybe it is in there, I'm not remembering it, do we want to make sure that somehow in our principles we are aiming to build a dashboard that ensures we don't, you know, sacrifice quality for cost or something like that? Like, maybe we want to really speak to that in our principles as well. Okay, enough from the quality person on cost.
Suzanne, I would have no plan to try and articulate things better than you do. So just that's not going to happen.
I do think it's a really great point about that the goal has to be the right care at the right time, and which sometimes might be much more expensive. I think having the longitudinal approach helps both from a system perspective and, when possible, all the way down to the member perspective, so that you can look further across time at that as well. And with Chima not here, I'll just reiterate his important point about access and efficiency as well being part of the per member per month spend. And to your point, sometimes the goal might be, look, depending on the strategy and the overall program and a reason that you're drilling down, it might be that you want it to stay steady, or it might be that you want it to rise.
Thanks, Bonnie. Karen, I think you're one to Dwayne, so please do, especially if you're, I imagine, maybe around the principles component to this.
Yeah, I mean, I think that's a good point, Susanna. I don't think it's explicit. I think, you know, to promote equity, you got to promote outcomes, but we can refine that. I also was just going to add that, you know, one way to lower PMPM is to increase the enrollment pool too, right? When we added Husky D, PMPM went down. That's because those folks are lower utilizers, and some of that's because they're healthier. Some of it's because they're not utilizing needed services, right? So I absolutely agree that there's some need for applying context to the cost data.
Thanks. Mike, did you want to weigh in?
Yeah, I'm sorry, Brad. I'm trying to find my hand here so I can raise it.
I got you. I could tell. I could see.
I'm looking here, but I do. I appreciate all the comments, and we certainly want to be able to make some of the draw out some of those relationships between positive quality and positive health outcomes for members and the financial piece. I don't think. One of the things that, in particular, maybe to what you just said, Karen, I think that in some cases there's, people, there may be some concepts out there around why costs are lower. And we certainly want to explore them further so that we can demonstrate or better tie out to the relationship between the PMPM and the quality outcomes and potential enrollment mix changes and things of that nature. So I think that's the next evolution where we want to go. And I think that what we're really relying upon, this group and this effort is to help us identify, those areas in which we can better target or link the investments to the outcomes, and to be able to focus on, which areas are most important to try to measure financial outcomes against. And it's very challenging because, obviously in the Medicaid program, there are so many moving parts, and it becomes difficult to target an individual financial investment to a particular quality outcome in many cases, given the many variables that are involved. But, we certainly would like to try to parse that out better for everyone and share that information, because I do think that we have a shared belief that the PMPM, the more positive PMPM that we've experienced in Connecticut, is related to the hard work that everybody has done around improving quality, and that there is a direct relationship between quality outcomes and better cost measures. So anyways, just wanted to support all of the discussion that has just taken place around trying to dive deeper into that area and to bring forth some of that information.
Thanks, Mike. Grace?
Yeah, and just to bring back into the loop, seems like I'm doing that a couple times today. Points we've made before, but are relevant to this context now. The whole idea of increased investment in prevention that may have longer term savings, but not be bound within the 2-year budget cycle, and the capacity to build that into the analysis so that we're recognizing the need to do upfront investment and the fact that it might not show up immediately in terms of outcomes. Certainly, improvement in health might show up longer term, and the corresponding savings might show up longer term. But that algorithm or that longer term perspective would be useful to use. And I know that there are some constraints around that, but it'd be helpful to be able to build out that whole time frame.
Thanks, Grace. Sandy?
Yeah, I guess my comments are similar to that. And in reference to what Mike was saying, if you look at something like prenatal care and the new maternity bundle, the outcomes of that are going to be seen not in the mother, but it'll be in the baby, the toddler, the child, and maybe quite long term if we're able to prevent, obviously certain kinds of long-term problems brought on by extreme prematurity, et cetera. And again, in what we do in pediatrics, so much is preventive. So much is something we do now to either prevent something that isn't going to happen, so it makes it really difficult to measure, or to have a more positive outcome that can be measured. And that's that's something that we focus on all the time, and but makes it difficult for us as a group to talk about where the financial part of it is going to be, because say for instance, in behavioral health, there's lots of dollars put on treatment and and many fewer dollars put into prevention and interventions in the 2, 3, 4, 5-year-olds. And I think those things are things that we have to, again, not to belabor the point about context, but I think that's really, really important, especially in the pediatric world.
Thanks, Andy. I think all points really well taken. That there's a lot of struggle to get outside of those few year budget cycles and measurements that we have, and how do you capture that return on investment, not just the actual financial return, but also that social return on invested capital, which is challenging to quantify at times. But obviously that aspirational nature of this, I think Mike and Bonnie are definitely thinking about how do we do that in the long run? How do we think about identifying those opportunities for upfront investment to then improve the health and well-being and actually both improve quality, but also save costs. And obviously this is not an easy thing to solve or everyone be doing it, but I think the need to do it is important. And hopefully this could be a vehicle to kind of further those efforts in the long run. Bonnie.
I just wanted to also reiterate, sometimes it's really important when we're looking at context of looking at both what we want to increase and what we want to decrease or avoid when it's potentially avoidable. So especially when we're looking at specific program outcomes, let's say, or sometimes system program outcomes, what we would hope to see is that efforts might decrease PMPM, but that we would be able to see increases, as Sandy mentioned, in Grace, in preventive and supportive community-focused services, and a decrease of inpatient and potentially avoidable ED as examples.
Thanks, Bonnie. So just looking at the time, I think I wanted to give Kelly an opportunity to weigh in on before we get to the visualization component. So I think Kelly's here. And so I know, just to make sure, just since I know I was struggling to make sure you were on these last few meetings, Kelly, to make sure we hear your voice on some of these issues and kind of where things stand with the work that where we've gotten this work.
Sure. So I apologize, everyone. We had some administrative issues getting me on these meetings. So I had a couple of notes. I think one of the reasons why behavioral health isn't being mentioned as much, because the executive order only talks about primary care and doesn't include behavioral health. And even though those of us in the industry, we see it as all, the governor himself made it seem we should only focus on primary care, when we know that's not the case. Without mental stability, it doesn't matter what the medical part is, because you're not going to engage in medical alone. One of the social determinants that I'm seeing kind of missing on all of it is transportation. If you cannot get to the doctor, you're not going to get any outcome at all, which is a huge struggle. And what I understand that it's CMS rules, but if there was a way to figure out how Husky C members could access NEMT, because Husky C is, the highest cost. Husky C is the most expensive group in Husky, but yet they don't have access to NEMT because Husky is a secondary behind Medicare. One of the things with behavioral health, if you're not familiar with this statistic, is that folks with severe persistent mental illness die on average 25 years younger than their peers. And that's something that, I don't know that a lot of primary care take into consideration, if they even know it. But it is actually a proven statistic. All of the social determinant conversations, to me, are saying what we really need is care coordination across the board for all Medicaid members. You go in to see your primary care or a specialist, you know, if you're lucky, you get 15 minutes of their time. So getting help from a primary with, you know, food insecurity and housing, or if they're homeless, whatever, you know, they don't have the time. And so if you're going to say to primary, well, you need to do all of these things, then in their mind, a 15-minute appointment has to be 30, which means they're seeing fewer patients during the day, which means that their bottom line is being affected. You know, it's a domino effect. I really, you know, currently care coordination is available to specific cohorts in Husky. I think that, you know, that care coordination or even using peers would go a long way to improving the whole person quality of care and helping those social determinants not be such a barrier. I don't expect my primary care physician to help me find more affordable housing. It just doesn't, that's not something that people, I think about. They don't go in because they have a cold and, oh, by the way, you know, I really can't afford my rent. Can you help me figure that out? Kind of, it doesn't make a whole lot of sense. And, you know, the other thing I would like to hear from providers is, what is the practicality of the day-to-day usage of all of this data? You know, I would kind of like to hear, you know, I know, you know, surveying members to get the feedback, but from the outset, so when all of this is said and done and presented on a dashboard, how are physicians, how do you see providers using this on a daily basis? And then on the flip side, is DSS going to use the data outcomes, I guess for lack of a better word, against providers for not hitting all of those benchmarks? And how would they, you know, are we talking sanctions, you know, retraining, things like that? I don't know. I guess I'm trying to understand the practical day-to-day usage of all of this data. We can do all of this and put it out there, but if it's not being used by the majority of providers, I don't know what the practical use of it is. And that's my feedback for now, Brad.
Thanks, Kelly. Appreciate it.
Sure.
And I'm happy to circle back with you maybe just because I know we're just on a few points and things. Mm-hmm. I'll reach out to you just to touch base, but I greatly appreciate your thoughts and input.
Thank you.
I want to make sure to give Susan a little bit of time to talk about the visualization component before we run out, since she's worked hard to think about about what this is going to start looking like moving forward. So Susan, I'll turn it over to you and I'll advance slides for you.
Thank you. So today it's just a real kind of quick and dirty, just some of the nascent concepts to at least to start to get some feedback and reactions. And again, once we really solidify the particular measures and the data, that also is going to kind of drive kind of the look and the feel. But I just wanted to start to think about how do we organize the web's presence, the splash page, you know, what some of the navigation, how do we make that intuitive? You know, what are some of the things related to the palette, the iconography, just starting to get some of those things, you know, kind of solid in my head, and starting to think about how do we organize some of these pieces. Next slide, if you don't mind, Brad. So I'm just going to focus today on three main areas. I did share something with Kate, Brad, and Deputy Commissioner Gilbert that adds a little bit more, has a little bit more of a walk up in terms of some of the principal pieces and tying that to the agency vision and mission and values. But for the sake of time, I'm just going to share for today just a couple of these areas. Next slide. So what you see here, I know it's a little small, is a potential conceptualization of what the web splash page might look like. I'm trying to be thoughtful about a color pattern, a color palette that's kind of inviting, that allows us to kind of easily see different categories and trying to maintain that particular style throughout. So you know, so for example, the header here that says equity lens does take some of the pieces from the principles, and that potentially could, by clicking on that icon, could lead us to a suite of measures that are specifically disaggregable by various equity and inclusive elements. That doesn't mean that wouldn't also exist in some of these other places, but just a way of kind of organizing and consolidating some of that. But that navigation, that page that you would then go to from there would have that kind of same similar orange amber colored banner. So again, that just kind of keeping, you know, some of that consistency and understanding kind of intuitively kind of where we are. The next banner I headed as kind of promoting a healthier Connecticut, and takes the icons, those visual cues from the matrix. I changed them a little bit, changed the order a little bit. And the intention there would be that each of those icons would be active, and by clicking on them would take you to an associated page that would have those breakouts of data based upon what we identified for each of those domains. The next banner area, that purple area, would be where we could start to archive and have be a repository for some of the other data. So I put there some potential data sources that we could link to, but obviously that could be as long and as much as we would potentially want. Obviously, with this, part of it is we're limited to the actual physical paper size, but being web-based, this will be continuous, so we really can. Real estate isn't going to be obviously as much of an issue, and also keeping it a place where folks can email for questions or comments. So this is just again some initial thinking about how in order to, excuse me, some thoughts about what the look and style might be for the initial kind of web and splash page for the transparency dash. And then this is just an example of I just took a couple of the items that Mike and the group, Bonnie and folks, pulled out for the financial pieces, and just I just actually took some of them and just changed the visualization and changed the color palette. So again, that we can keep some kind of standardization with some of that. But again, just showing what that navigation would be. So clicking on that managing costs icon would lead to a page that includes, these data and other such similar data. Next one. So very similar to what our friends and the finance subgroup did. I'm also thinking about this in terms of phases. This is clearly, and I think we've started to flesh some of this out. This is going to need to be an iterative and a multi-pronged dynamic process. Figuring out exactly which data do we want to present, how do we want to present them, is going to impact kind of the time frames and some of those milestones. I'm trying to aim for something that will allow us to publish at least some version of these data around September. It'll likely be that at that stage that these are more kind of dynamic and established and well vetted measures. If we are needing to do something that's majority interactive, obviously that's going to push back the time. But I think that if we can identify some really solid measures and we can stand up in a static way, at least to start with, we can do some of that back end, that ongoing work to do the vetting related to some of the interactive. So, for example, when we're talking about that interactive, when we're talking about some of those data that potentially may tie back to a data set that is at that person level, even though it's de-identified, when we are doing some of those filtering and cross tabulations, it potentially will allow, it potentially could, if we don't do our vetting and due diligence, allow for deductive disclosure or re-identification. And obviously that's not anything that we want to do and are looking to do. So we want to obviously do a really strong testing phase with anything that would be interactive that might involve kind of underlyingly involve kind of client level data. You know, some of the fiscal data, if it's, again, not necessarily tied to an individual, you know, record per se, an individual person record, it may be a little bit easier to do in an interactive way, and maybe we may be able to push out a little more quickly. But some of the other domains may take a little more time in order to do some of that vetting to make sure, again, we're not in any way potentially compromising the identity of anyone that may be part of our member set. So July, really trying to do that finalization of what those, you know, those kind of core measures are. September, doing some initial publishing, and then thinking at the end of the year to do some, you know, some enhancements. And I hope what that does is give time for feedback, that folks have the opportunity to share with us some of their thoughts about additional, you know, data pieces that we can be doing, the actual kind of look and feel, the navigation of this, and that we can then think about, okay, here are some tweaks that we want to do for 2022 so that we can make it much more accessible and much more engaging and more consumable for folks. Next slide. Oh, and so phase 2 is where, you know, I'm thinking about that really being about doing some of that interactive piece. So a little bit later down in terms of the calendar, in terms of identifying what some of those data pieces that we think are really poised and make the most sense to do in an interactive kind of way, and then doing this in kind of batches. So, you know, what are some of the lower hanging fruit that we can make interactive, and start with that, and then subsequently moving therefrom. Starting to figure out what that prioritization should be, and what those particular modules should be. Next item. And phase 3, I really do see this as being very cyclical and continuous. And that has to do with kind of the maintenance of the dashboard and the refinement of the data, continuing to improve that user experience and that user interface. Thinking about how do we start to incorporate some of those aspirational and innovative measures. So how are we expanding the availability of data and also that data menu? So that would be something, again, just kind of ongoing throughout the life of this particular endeavor, where we're always looking at making improvements. Next slide. Okay, so this is the last slide in terms of the plan. And this is just very nascent and just still very draft, but just trying to put some potential timeframes down in terms of what are some of the activities and deliverables that we need to produce, and by when do we want to have those done, and when you know, certain things we want to have started. So, you know, obviously getting that initial web and dashboard concepts to you this month. Building out a little bit more of the development plan, trying to get that to folks by the end of this month, finalizing the measures and the data. Certainly, I would hope by the end of June that we really do have all that very, very solid. That we do also finalize the concepts in terms of the web and the dashboard itself. So obviously your feedback will be important to figuring out what we need to do in order to make that satisfactory to users. Finalize those recommendations, as we said earlier on today, and then around July or so to really start to do some of that production. So once we actually kind of know, you know, what all the measures are going to be, have some agreement on the look and the feel of the web as well as the dash, then we can actually start to do some of that building. And as I stated before, try to start doing some publishing iteratively in September, identify those phase 2 enhancements, finalize and approve what some of those initial phase 2 enhancements are, and then obviously also doing that kind of ongoingly implement, identify what those phase 3 updates are going to be, again, also being updated, ongoingly, and then just kind of a cycle of finalizing and improving those phase 3 updates. So again, I know it's very quick and I know it's very high level, But we did want to at least get your thoughts and at least share with you some of what we're thinking in terms of, how do we visualize this? What are some of the ways that we can develop this, design this so that it's inviting, that it's fairly, that it's fairly intuitive, and also figuring out, ongoingly, how do we make those enhancements so that it is meeting folks' needs and it is comporting with the intent of this body.
Thank you, Susan, just for putting this together and really doing so much work behind the scenes to get us where this is. Bonnie, go ahead and jump in.
I just wanted to say, especially as someone who has mentioned interactivity a lot, I just want to stress that everything, Susan, that you described is really incredible, and it's a very aggressive, impressive timeline. So, and I do think, phase one, starting with static and doing all the careful vetting, that I deeply appreciate all the work that goes into that. Looks really fabulous, and again, very aggressive and impressive.
Thank you. Yeah, we it's definitely aggressive, but we definitely want to start to turn some of this around. Fortunately, this is also embedded into some work that we're trying to do more broadly. I didn't share it here for you guys, but I did share with Kate and Brad just how I'm hoping to kind of have this interlace with what we're doing for our enterprise dashboard presence. So having within that broader one for the agency, a link that specifically is the transparency for Dash. So again, just really trying to, thinking about this almost from like an agile approach, for system development. So really thinking about different modules. So I appreciate that, Bonnie, but it is our intention to try to to get something out, sooner than later. Because again, it really has been just such a dynamic and generative process, as Kate noted, and I think it's important for us to try to get some information out to folks as soon as possible, to really kind of respect the time and expertise and all that folks have put in over the past several months to get us to this place. So I'm excited to do this. It's daunting, but I'm confident that we will be able to hold to fairly closely to this timeline.
Thank you. I'll just go back to just some of the other, see if there's any other thoughts about either visualization component or anything else that Susan started to mock up, just to see if we have any initial other comments. Karen, please go ahead.
Yeah, I'll just chime in and say, I think as new metrics become available through some of the alternative payment model projects that are underway, it would be great to see those rolled in over time. And like you said, I'm looking forward to hearing what the plan is for keeping this a living and iterative project. But I think it's a lot, and I'm looking forward to seeing it.
Thanks, Karen. Ben?
Thanks, Brad. And I echo you, Brad and Bonnie, that Susan, this is really impressive work. I agree, it's very, very aggressive, but I'm looking forward to seeing this unfold. Just one suggestion, and I don't want to overcomplicate things, but I do wonder if it'll be helpful. We've talked a lot about what the audience is going to be for this, and I wonder if there may be a branch point at some point early on in the viewing of this that one can identify themselves as either patient consumers or provider, healthcare professional, or researcher, so that we may have different pathways for those kinds of audience members to go down. And that may also allow us to track who's using this in an iterative way, if we're able to kind of, measure clicks and so on, of who's going in which direction. Just a suggestion.
Thanks, Ben. I'm wondering if that's maybe even a phase 2 approach, where we kind of try to get everything we have up there, and then try to figure out how do we kind of make it for each group or something along those lines, as part of, I think, Susan's timeline is think about what our phase 2 enhancements are, and maybe that's part of those phase 2 enhancements. But I think it's a great point. So thank you. Other thoughts? So I think we have about just under 5 minutes. So I just want to wrap up. I appreciate we had a pretty aggressive schedule full of lots of stuff today, and I appreciate everyone kind of helping us move through everything and really get these slides together, and kind of just really appreciate everyone's involvement in this process. So I think there is actually a need probably for, I wasn't sure if the principals subgroup would need to meet again, but I think maybe it makes sense just to look at it with the framework of the cost. But maybe my guess is maybe the finance and the principals have like a quick meeting, because I think those are pretty close, and maybe the quality subgroup needs to meet. We need to meet a few more times to kind of to figure out how to incorporate some of the other comments that came today. Does that sound right to everybody? I want to check in to make sure that sounds like a good next step, because just as a reminder, our last meeting is June 29th, so it's coming up. And I think we're getting pretty close to having something that we can kind of finalize as a report out. But and Ben, is that a legacy hand? I see it's, just want to make sure I'm not missing a comment from your legacy hand.
Yes, apologies.
Oh, no worries. So welcome any thoughts on that. I will be drafting recommendations incorporating the overarching goals, principles, et cetera, from the subgroup into a kind of early draft of our final report. Again, I'm planning on doing this in a slide deck format as of now, including language just for ease of use and practicality. And then I wanted to just make sure, see if there's any other thoughts, things that we haven't, that anyone's like, you know, we really should have thought about this. This is kind of the last opportunity to put those things out there. And so I just want to open it up to see if there's anything that's on anyone else's mind that they want to raise or bring up at this point. I'm sorry, I know I've realized I haven't really been able to monitor the chat, so I may have missed some comments along the way, but Susanna, go ahead.
Mine is just to say, you know, I mean, especially seeing what Susan is capable of putting in front of us. You know, I think there's a lot happening in this space in lots of states. I don't pretend Connecticut's the only one that's thinking about this, but I do feel like a dashboard that covers these areas that's public on that timeline is an incredible thing. And so my main thought is make sure that people hear about it, that other states can learn, that, you know, that you get some credit for getting this out in the world. Maybe I'm leapfrogging the success already, but I have total confidence in Susan mostly. And so I just think, you know, if we really do get information about population health for the state of Connecticut in a transparent manner where it's accessible to everyone, you guys should make sure that the world knows you're doing it. I think it's really important to get that visibility.
Thanks, Susanna. Appreciate that. I also believe in Susan, so I think we have a similar belief there. Any other thoughts? Not seeing anything. Kay, do you have want to make any final remarks kind of as we close out of where things are? I'm happy to make a few as myself.
Yeah, not much other than just to say, like, this is so great, such a cool process. We're very, very excited about it. And I did just want to say, Brad remarked that we're going to have to use a slide deck format or something like that for the final report. We'd like it to model not being that sort of, you know, text-laden issue brief that's highly typical of state agency and board recommendation reports. We'd like it to be more dynamic and visual. So if you have any thoughts about that, you know, I think all these pieces model something different than historical practice, and it feels important to us. So we'd love to hear from you about that. But just many, many thanks. And back to you, Brett.
Agreed. Thanks, Kate. Yeah, I think that's an important piece, that if there's feedback about that final presentation, but I think, again, trying to do something maybe a little bit different is useful here. And again, just thanks for people's commitment and engagement and commentary. It's so helpful to move this forward. It does feel very, you know, iterative and generative. And I really appreciate that. So I think we can end a minute early. I'll send out for those on subcommittees. I'll ask Jody to help schedule. I think probably maybe 30 minutes for the principals and for the finance, and maybe an hour for the other one, just to help us move forward before our next meeting. So I'll do that in short order, and look forward to seeing you guys in about a month, and some of you sooner. If you have any other comments or thoughts, feel free to send them my way in the interim. All right. Thanks, everybody.
Thanks, bye.